All right, we will get started here. So good afternoon. Thank you everybody for joining the Pediatric Grand Rounds. It is my pleasure to introduce today's speakers. They are two colleagues that I have the privilege to work alongside and learn from and call my friends, Dr. Lacey McCormack and Dr. Kimberly McKay. Uh, Dr. McCormack is a nationally recognized expert in rural health and public health nutrition, serving as Director of Rural Research at Avera Research Institute and Associate Professor of Pediatrics at USD. Her work focuses on understanding and improving food environments, food security, and nutrition-related health outcomes, particularly in rural and underserved communities. Lacey is a leader in program evaluation. She brings a thoughtful, data-driven approach to understanding what works, for whom, and how to expand that impact. She has led and partnered on numerous large multi-site studies and community-based initiatives, always grounding the science in real-world application and measurable outcomes. Dr. McKay is an OBGYN medical director at Avera Research Institute and an associate professor at USD. She has spent her career advancing maternal health care. She is a systems thinker and innovator leading initiatives in perinatal quality, telehealth, and maternal safety. Her work has shaped how we deliver obstetric care across the region, always with a focus on practical, scalable solutions that improve outcomes for moms and babies. Together, they will bring a complementary perspectives, public health, and clinical care, which I am very excited to hear about in their talk today titled Addressing Food Insecurity and Stigma in Clinical Setting. And I think that they will speak very directly to the realities of our patients and families and what they face every day and the challenges, and will challenge us to think differently about how we respond to them. Please join me in welcoming Dr. McCormack and Dr. McKay.
Can you hear me online?
Yes, we can.
No pressure after that introduction. I appreciate it. Thank you, Dr. Pocket. So we are very excited to be here today to talk about food security. This really was sort of a kismet presentation in the fact that Dr. McKay and I are getting to speak about this from a clinical and public health perspective. Just so you know, we'll give some background information on food insecurity, both nationwide and in South Dakota, talk a bit about stigma and different settings and how to address that, and then sort of how to operationalize all of this in a clinical setting. These are our community members, our neighbors, our patients that we're talking about, and we're excited to share some of our real world experience in this arena. So as I was getting ready for this presentation today, I was looking up different statistics, and I was really happy to see this collaboration between FRAC, which is one of my resource homes, the Food Research Action Center, collaborated with the American Academy of Pediatrics on this policy and position statement around food security for children. And so there was actually a really nice toolkit that was published in this space that I'll be drawing from for this presentation. But it just re-emphasized to me that this is not just something that I think about, it's something that we all think about, we all want to do something about, and it's important in the clinical space as well as public health. I put here the definition of food insecurity, sometimes used interchangeably with the term hunger, but I wanted to call out that it is the limited or uncertain availability of nutritionally adequate and safe foods, or inability to acquire acceptable foods in socially acceptable ways. So this is not, you have food that's expired, or you have to scavenge or get it out of the dumpster or things like that. It is getting food that supports a healthy lifestyle in socially acceptable ways. There are a lot of reasons why we should care about food insecurity, both from a social perspective as well as a clinical perspective. It's a little small here, but you can see that in children, food insecurity is associated with poor health status, developmental risks, mental health problems, and poor educational outcomes. Excuse me. And I like this graphic as well because it shows that food insecurity can present itself in a clinical setting in a few different ways. We'll talk a bit about how to assess food insecurity, but there are also other cues that you might notice. These are food insecurity or hunger facts from 2024. About 1 in 7 households experience food insecurity, and this translates into nearly 50 million Americans. This also affects a lot of children, even though parents and adults in their lives do what they can to shelter children from food insecurity. We still see a high prevalence of food insecurity among children. I wanted to add that we see higher food insecurity in rural areas as well compared to urban areas, and a higher portion of households in urban areas and rural areas experience food insecurity compared to suburbs. So there's this weird outlier in the suburban areas, but this comes into play when we think about solutions and how to address food insecurity. This is not just a problem nationwide, it's also a problem in South Dakota. So over 100,000 people in South Dakota are food insecure, and 20% of these are children. I pulled this map from Map the Meal Gap, I think it is, and it highlights how we see this in every single county and how it ranges from 8% to nearly 30%. Like I mentioned previously, there are issues associated with trying to solve this problem in rural areas. For example, I love to tell this story because a friend of mine was presenting at a meeting in DC. She has always lived in an urban area. She was working in the food insecurity space. She was talking about all the solutions they had come up with for food insecurity. And I asked about rural areas. I said, well, how does this translate to rural areas? She's like, we have the solution. We have partnered with Instacart. You're welcome. And I said, have you ever been to South Dakota? This was also like 4 years ago. Instacart is not as ubiquitous as it is in other places. We might have to rethink that, but great start. Appreciate the enthusiasm. So what I like about being in the nutrition space in South Dakota is that we have the same problems as urban areas, but in rural solutions. And I think that our researchers and community organizations and people across South Dakota are really creative about finding solutions, and we're going to talk about what some of those can be. There are a number of tools that can be used to assess food security. Most of these are used in a research setting and help us get some of that nationwide data on food insecurity prevalence among adults and children in the US. This data is available from USDA. What I am going to talk about is what's called the Hunger Vital Sign, which is a 2-item screener. This is most practical and relevant for clinical settings, and it is what is recommended by the AAP for screening in a clinical setting. You can see that this is 2 questions. It asks about experiences over the past 12 months with worrying about food running out or food having not lasted and didn't have money to get more. And if you answer sometimes or often true to either of these questions, you are deemed food insecure or in need of additional. In terms of implementing this in practice, I, along with the AAP, recommend universal screening. This means screening all patients at all visits. This helps us to not assume anything about patients and what we think their experience is. It also ensures that people don't feel singled out or left out. There are some recommendations here for if you must prioritize screening, where are the most important places to do that, or what cues should you be listening for in your interactions with situations that might indicate that they are food insecure. We have this conversation quite a bit when it comes to screening and, what if someone is coming in every week because of some condition management? And, what if they got food somewhere else at a different place earlier in the week that we didn't know about? Universal screening takes all of that out of the equation and just lets people tell us if they are in courses, we can all time, things like that, but we don't have to pay. Some of the other questions that come up when thinking about screening and how to best screen, we've had these conversations in my organization. Do we have the nurses ask this when we are rooming a patient, or do we hand it to someone upon appointment check-in? This really was a point of consideration when talking about our pediatric population, because you have parents who might not want to answer these questions in front of their children, particularly among adolescents. And so there are recommendations to ask the parents questions separately from the children. And if you are interacting with an adolescent, ask them in addition to their parents, because they might have a different experience than their parents and report this. One of the other things to consider about doing this on paper or through a portal versus doing it face-to-face in office is if you're asking someone these questions in person, it might bias their responses. It's probably easier for me to put down on paper that I'm struggling with this than to say it to someone's face. And we're going to talk about that a little bit later in this presentation. A few of the other considerations on here are to normalize the screening statements. So saying things like, grocery prices are so high right now, right? Would you mind answering these couple of questions about how you're dealing with food resources in your home? Not approaching it as, you have enough food, right? Why don't you answer these questions and we'll make sure about that. The other thing in here is, especially when it comes to parents, ensuring that parents know that this is not something that is going to get their children taken away from them or will be used against them as a sign of poor parenting. A lot of people struggle with putting food on the table, and we are trying to assess that and help do something about that. Using the patient's preferred language is always recommended, and no matter what the results are, providing resources to the patient. So they may say that they don't have an issue, even if they do. And so if you screen and provide resources to everybody, those resources are getting into the hands of someone who might not flag as food. This is just an example of something that we use in our Sioux Falls clinics that are doing this screening. We have tried to highlight some of the biggest places where people can go and get food and also meals. We have created this for Sioux Falls, Pierre, and Parkston, and have it in both English and Spanish available. And then this QR code links people to additional resources. A few other things that I wanted to mention. Food insecurity is a sensitive subject, and parents do often try to shield their children from it. It's one of the reasons why in the expanded food security questionnaire, there are questions about the household, questions about the adults, and questions about the children. And so some of the questions for the adults are, do you skip meals? Do you go without food in order to provide it to your children? I think the second point on here is one of the most important points and goes back again to universal screening. You can't tell by looking at someone or by their insurance status if they are food insecure. We see food insecurity in patients with all insurance statuses, and we can also see food insecurity coexisting with obesity. So it's not appearance or wealth related or anything. Stigma surrounding assistance programs and emergency food has long been identified as a barrier to participation. So one of the things that we're going to talk about is how to help normalize handing out information about resources, encouraging patients to use resources, and supporting patients in using and accessing resources. One of the classes I used to teach at SDSU was a public health nutrition class, and we talked about using SNAP benefits and what they should be spent on. And I remember a student saying, I remember when someone came in and it was SNAP day and they were trying to buy a birthday cake for their child. You think SNAP participants should have a birthday cake? And I was like, do you think SNAP participants should not have a birthday and not be able to celebrate a birthday? So just thinking about people and their experiences and reinforcing these types of supports and reducing stigma as much as possible. One of the ways to do this, and this is an example from the toolkit, is to have these supportive resources available in clinics. This highlights different food assistance programs or food resources. It says free healthy food is for your growing child. Learn more about these programs. If you know about them as physicians or providers, and can speak to them and say, yes, this would be great for you to use. Here's resources about it. As my friend Dr. McKay says, that physician reinforcement can be really helpful for patients. Hearing it from their doctor can really help them access these things and not feel so bad about it. I think in addition to this, just knowing about the different food-related resources that are available. Big ones are SNAP and WIC. I know this is very small, but I will provide these slides afterward for you to take a closer look at these. SNAP, formerly known as food stamps, is that monthly allotment of money. It says here that the average benefit is about $29 for the week per person, or about $1.39 per person per meal. The majority of SNAP recipients are children, and so being able to speak about the programs, offer resources about how to access them, encourage people to sign up for them if they are able to, can go a long way in addressing food security. WIC is up here. That is the one that is tailored to meet nutritional needs of pregnant women, infants, and children. We also have the school meal programs up here. I didn't know this for a long time because I was like a school breakfast in London. But I remember when I was in a faculty position and talking about the benefits of these programs, one of my colleagues said, the school breakfast program is for poor kids. And I was like, it's for everybody. It's at school. My mom had to drop me off on the way to work. There wasn't time to eat breakfast. I didn't know that it was considered a poor kid program. But saying things like that, talking about programs like that, does not help to reduce stigma around their use. And so talking about the benefits that these programs provide to millions of children every day in a low-cost way is a better way to sort of approach that. Stigma is alive and real, and we are asking participants questions about it. At Avera, we have a Healthy Start program that provides information, education, and resources to pregnant women and their families with infants up to 18 months of age. Some of the work that we're doing through our community consortium is around food security in the Sioux Falls area. So we held focus groups with eligible individuals at the Teddy Bear Den to talk about their experiences with food insecurity and accessing different resources to help inform some other work that we're doing in the community. I just wanted to provide some summaries of some of the themes that came up based on questions that we were asking. And again, this was 8 moms. They had their kids there with them, and we talked about these things over lunch at the Teddy Bear Den. So we asked about experiences with getting enough food for them and their family. And something that came up quite a bit was having special diet needs and not being able to meet those needs through the resources that were available, either free food resources from pantries or food banks, or programs like WIC. So they're trying to access resources, but they don't necessarily work for their family. From pantries, they cannot get the food that is best for their families and find themselves not using it or having to throw out things that they receive. Something that they mentioned again and again is that they did always try to give away things whenever possible. So for example, if they were getting diapers that they were the wrong size, there was a diaper exchange Facebook group that they were sharing with. There were people who were getting food from pantries that they weren't eating and were taking it to the Bishop Dudley house to give it to someone that could eat it. A lot of the people in these focus groups were talking about wanting to provide healthy foods for their families, but not getting those foods from food pantries, or not being able to sort of pick and choose what was best for them and just be handed a box and saying, this is what you get. Thank you for stopping by. So people really were trying to do right by their family and make healthy choices, but were limited by the options that were given. This question was about how people were treated at food pantries or at food pickup sites. We have found this in other research as well. It's not necessarily the people who are in charge of these or are full-time employees at these organizations or with these groups, but volunteers could use some training on empathy and social interaction with participants. And we've got a toolkit for that and we're working on getting it distributed, but most interactions that were negative were with volunteers at these places. So for example, someone will say, my child has a food allergy, they can't eat this, could I exchange it for something else instead? And they're just told no. If you're really hungry, you would take it. Beggars can't be choosers, like those kinds of things. And so it's hard to hear that when people are advocating for themselves and their needs, they're being turned down. But these are the experiences that people are having. And so some of the work we are trying to do at a community and systems level is get some unified uniform training in this space around how to interact with participants, but also how to set up food pantries and food giveaways in a more dignified way. So providing a shopping experience, saying your household is this size, which means you can grab 2 things from here, 3 things from here, shopping for things that work for you and your family, as opposed to just being given something and told to be happy about it. So I've talked a lot about food insecurity and what we might want to do in a clinical or health setting. I'm going to turn it over to Dr. McKay, who is going to talk about the realities of trying to implement this work.
An obstetrician in a room full of pediatricians. Dr. Bogle is here. He's one of my child's pediatricians. I feel really bad. Thanks for having us today. I want to just talk for a minute about the realities of the evidence, right? We all know that healthy food is incredibly important. We all have, I remember, so I'm old enough. I won't tell you how old you all yes, but I had friends that would go into the commodity store. And that food insecurity was addressed at the state level in places where, that was apart from the health system, and the physicians and clinicians didn't think too much about it. Lacey and I have both been at the Research Institute about the same amount of time. And we met each other. I had been funded as the PI on a grant for maternal health, and foundational to the project was screening for social drivers of health, which I'm never one to back away from. We got to do this thing. It's the right thing to do. And at the same time, Lacey said, well, I know a lot about that and food insecurity, and let me take that over. So between the two of us, we knew a couple of things. Number one, we know that in pregnancy, what is very important to pregnancy actually is healthy food. And then we also knew that screening was the right thing to do. And I, at the time, was leading the OB/GYN service line at throughout Avera, and introduced this concept of we're going to do social driver screening. And oh, by the way, the Centers for Medicare and Medicaid have now mandated that every hospital and clinic in the United States do social drivers of screening. It's the law. It is, you have to do it. And I was all excited, and none of my team was excited. And it was really, you know, as I think about, as providers, now we think a lot about patients and wanting to be present to what their needs are. But at the end of the day, when we have to ask hard questions, when we have to put it into our workflow, that has implications for how we do the work. So like one thing I was thinking about is, yes, it is great to get an adolescent in a room by themselves and apart from their parents, but how feasible is that if you've got 25 patients in your schedule, right? So when we talk about these kinds of systems change, getting the evidence to the patient takes a lot of thought about how you're going to do the work. The first question is it feasible? And if it's not, why not? I want you all to leave today thinking about how we deliver healthcare. Healthcare isn't just about following the rules, following the evidence-based practice. I bet every single one of you in this room has seen a pediatrician that didn't do it the evidence-based way. They did it wrong. And we say in the implementation science world, it takes 17 years for an evidence-based practice to penetrate all the way through the health system. And if you look at the evidence on getting people to take an aspirin after a heart attack, you follow the trail of how difficult that was. So as you think about when, you know, these evidence-based screening tools, when you think about projects like this of why aren't they doing it right, it almost always is a systems problem because people haven't really considered the work as done. There is a difference between the work as imagined and the work is done. So what I want to talk about today really is the healthcare space. We of course think a lot about how patients receive the care. One of the things that I love about our work at the Research Institute, we do a lot of qualitative research. We ask patients, what's your experience? And it's incredibly rich information. We also should be doing the same thing among ourselves and among our colleagues to say, why was it hard? And at the end of the day, when you put a system in place to help patients, at the end of the day, the way you know you do it right is no one complains about it. No one's gonna ever thank you for doing the right thing. If you get into leadership in healthcare delivery or whatever, you will become leaders over time. But at the end of the day, no one's gonna thank you, but they will complain if you get it wrong. So what I want to do is take you through some newer studies that have looked at implementation of social determinants of health screening, which is a little bit separate from food insecurity per se, but because of the CMS guidelines or the CMS mandate of we all have to screen now, that whole like federal mandate broadened something that for good or for bad, I mean, it's always good to know these things, but know that each domain of the social determinant screening actually has its own like little particular things that are difficult. So I'm starting with the implementation. This is like the real world of how we would like it to work, where we have better outcomes, where we're getting the data integration, we have closed loop communication, we have a good system of workflow. That's work as imagined. So let's talk about getting to work as done. Now, physicians and residents, they don't always ask us about how to do things. They just say, go do it. And sometimes we're too busy to go to leadership meetings or to go to these things to actually give an opinion. We talk a lot in the implementation science about barriers, because if you have a really strong barrier, it is not going to get done. People will dig their heels in. So when physicians and residents were asked about social drivers screening, they talked about this unsolvable problem. You're going to make me screen, and what do I do with the information? And when I thought about this, I'm like, well, where are the food pantries? How does that work? And it was Lacey that's saying, okay, we're going to get this QR code and then they're going to screen it and it'll have the resources. And it was much different implementing in South Dakota than it was in Iowa, because Iowa was further out. We didn't have a line of sight on all the resources. So Lacey, she does the work, I'm not going to lie, but we had to do a lot of like process mapping to say, how do we figure out how to get this unsolvable problem solved? And at the end of the day, when you're asking these hard questions, there is a lot of moral distress, maybe not a large amount, but over time it gets really, really hard. And it is heartbreaking. It's incredibly difficult when you say, yeah, I don't have any food, and then you can't do anything about it. The other piece is there is a complexity of need. In one study that we cited, there's almost a third of pregnant patients who screen positive for at least one social driver. And Lacey, what are our social drivers? I haven't looked at our dashboard for a while in pregnancy, but it's much higher than you would imagine. And we see, at least in our footprint, that great disparity in rural versus urban. So it's incredibly important that you be understanding of, if you start screening for these, you will find them. And they may be at higher rates than you think. But what helps? The big question is what helps. So sites that saw significant reductions in provider burnout around this had a dedicated either community health worker, medical assistant. They really had someone else helping them do the work that really took off that mental load. And this kind of speaks to what we'll see in a slide down here later about patients and how they feel comfortable asking these questions. Lacey mentioned when we as providers, sometimes we get in people's faces, we don't mean to, but if you've had a long day and you say, yeah, so do you have any food? None of you have ever done that before, I'm sure. But at the end of the day, you have to be able to read your patient and read how they're going to receive those questions. If they don't know you, they may not answer honestly. So again, having those specialized roles and a pathway where there's dedicated work, and then also closing the loop on I screened, I got them the resource, I closed the loop. So nobody wants to screen for anything if you don't have a care pathway in place. So as a general rule, when I'm looking at healthcare programs or screenings of any kind, I will dig my heels in about putting a screening unless I know the care pathway and I know how the resources are going to work. And at Avera, we know we need to do general, like universal substance use disorder screening in pregnancy. We do not do it yet because the paucity of resources is enormous, and we still don't have figured out how we do that and keep patients feeling safe and secure. We know that when we do that, it becomes the determinant to prenatal care. So I know that's kind of off topic, but at the end of the day, if you're going to be all gung-ho on a screening thing, don't even think about it. The first question you should have is, what can I, if I'm using this screening, get people help? Do I have the help that they need? And when you talk about nurses and clinical staff, this is a time burden on them. You all are kind of young. Well, some of you are young. I see some gray hair out there. But Joe, do you remember when we started having to do interpersonal violence? Do you feel safe at home? Click the box. And we rarely found out. I don't think I ever found out if people actually felt safe at home. It was just a click the box thing. So it can be, you have to be very, very careful about being deliberate and into how you're, that it's not just checking a box. The other thing is that I think it's a little bit different in health systems, but care variation is real. And if everybody's using a different clinical screening tool, some can be very long, some can be very short. If you're using a different tool, it doesn't work. So maybe that's not as important in a health system where generally our EMR governances have to dictate what we put into play. But again, it's incredibly important that there be consistency into how you're screening. Now, what helps? Task distribution is really, really important. So the sites that were most successful utilize medical assistants to capture the data, and 71% of patients were more likely to get screening when it was integrated into the initial intake. Not done in the room necessarily. Now, obviously, when you're talking about food insecurity and you're seeing, that's kind of it can be a different thing, but at least the initial screening where you say, yes, it's positive, and you start to think about what's that deeper dive into those questions, that can be really important that you just do that screener, and then you're going to have to ask follow-up questions. The other thing is that staff having screening literacy. We were in our Healthy Start community partners. It feels like a little bit of a support group to me sometimes. They're so helpful. But I was like, it's really hard for me to ask these questions. I don't like it. I feel like maybe this is a South Dakota culture thing, but it's like, is it really my beeswax to ask that? Like, I feel like I'm pushing, I feel like I'm prying, but if I can get and have an understanding of how to do it in a way that is soft, in a way that is understanding, and that it's for everybody, and I think Dr. McCormack said that many times, doing it for everybody is also a facilitator to having this be successful. Now, we don't know how the patient, so we're talking about work as done in our world as clinicians. Now, patients may not always respond this way. That's why it's incredibly important for the public health data to be like, what do we need to think about when we're putting it into our own workflows? Dr. McCormack talked about the patient perspective. This is per a clinician observation in several of these patients, but patients, it is very real that stigma is real. So patients underreporting the need because of fear. So, you know, many patients will not admit, and then as they get to know you, and if you screen every time, all of a sudden they'll start screening positive for things. And then of course, this concept of how much do they trust you? And so you may have to build that relationship over time. The one thing that I thought was super interesting from the perspective of screening is this concept of digital privacy, and you talked about it with paper as well. So this digital privacy of, I'm gonna just give you a tablet and here's the paperwork you fill out and it takes you through a series of questions. Patients seem to really like that much better. And then also patients were more likely to engage in the screening if it was relevant to their healthcare goal. And I think that's a really complex one. So I'm interested in when it meets their goal, because as we think about food banks and things like that, that may not have the food that you need or that you like, or that you can tolerate. Some patients may at this point of like, if it's relevant to me, great, but if it doesn't actually meet my needs, I don't even want them to ask. And then the last piece is around the health system perspective, where our biggest pushback, like when we started talking about social drivers screening in Sioux Falls proper, people felt a lot more comfortable with it. And it was at our smaller rural sites that are like, dude, what do you want me to do with this? Like, I don't even know, the next food bank is 50 miles away. Or my patients, their main source of food is at the gas station. What do you want me to do about that? So this whole concept of a rural desert, and we talk at the Research Institute a lot about food deserts as well. So if you're doing social driver screening and you're screening for housing instability, and there's zero local housing resources, like it feels, again, back to that moral injury, it just gets really, really difficult to know what to do with these things. The other piece around social driver screening is this care fragmentation concept. I think this is getting better, but there are places where, you know, WIC may know about housing insecurity. Department of Social Services may know about housing or food or transportation insecurity, but none of our data sources talk to each other. There's no layer of, you have to kind of work to get to it. I think, again, there's in our EHRs, there's this, you know, you can go find the data. However, and we're getting ready to move to Epic. We're all very excited. I'm excited because I heard that it does C-sections and it takes call. Mm-hmm. So you laugh. I was hoping, but I do also know that Epic has about, everybody's like, there's 10 ways to do things, and I'm like, well, how many clicks does it take you to get to the information? How many clicks? So you guys think about that. Is it hard to get to the social driver screening in the EMR? Do you know where it is? Where is it? Is it easy to find it? Do you look at it every time? How many clicks does it take you to get there?
One click.
Just one click?
You can hover over it on the left side of the screen.
See, it is Epic. It's gonna be a Christmas miracle, I'm telling you. In my EMR current state, and this is like, you know, Epic's only 50% of healthcare records in the United States. You can imagine other healthcare systems, it's just not that easy to get to. So, but what, again, just to talk about the public health perspective on, and then the health system perspective on universal screening, even commercially insured people will have, so this one said 14%. I don't know what yours said, 16, 17, something like that. Mm-hmm. And then then here is the big thing, is this concept of like an interagency referral. So a lot of social drivers things, like if somebody has housing insecurity, there's a pathway at the state level to be able to refer, but right now nobody's records really talk. So, and maybe yours do, but there's this people that figure out this pathway to get to state supported services actually do much better. So there is hope about these things working. So again, if we go back to what's our ideal work as imagined versus work as done, we talk about that concept of patient-centered screening, validated short tools, and then this concept of role specialization. So again, when you're working in your health systems, if they're coming to you as physicians and saying you have to do this, your next question is, what are the roles? What is the role specialization that's going to support me in doing this work? This shouldn't be like doctors. Is everybody doctors in here? Can I just be all like special about being a doctor? Okay, I will. We want to just be doctors. We want to do the clinical work. We don't want to have to do the tasks that take away because we've got enough to do. So it is again about that task distribution, because already we know it works better if you do it that way anyway. But if you go to a clinic, especially in rural, and you think about how to run your practice or how to do it well, it's really important that you understand that you can ask that question and you should ask that question, because over time you just keep getting put screening on top of screening on top of screening, and pretty soon you're screening everybody and you're not actually getting to the medical complications. So, I mean, at the end of the day, Lacey's going to kind of bring it on home here. But we had a pretty good, successful run with social determinant screening, found a lot more than we thought we would. And we figured out how to do it better because there were a lot of complaints, and we iterated and iterated, and I think we've got a pretty good fix at this point.
Screening has returned. I love the work that I get to do at the Research Institute because I have over here like my long-term research interests that I get to pursue and, work 20 years to get into the field. But I am also part of a health system that is working to implement changes and impact lives every day. And so the social determinants of health screening, which took a year to get into the EMR, by the way.
So long.
I'm a researcher and I'm like, here's a study we want to do, implement the protocol. You don't just put something into the EMR. I have learned that. But anyway, I am part of a health system that using information from community needs assessments tries to figure out what they can do to support community members and the needs that they are facing. And so this food security issue kept rising to the top of community health needs assessments. We were implementing screeners around social determinants of health, and we wanted to figure out how to make this work. Our friends at Sanford allowed us to tour the pantry situation they have at the Children's Hospital. I know there is also something out at Monument, so we are not the only ones working in this space, but we have found a model that works for us. So we have our 2-question screener that we have implemented in certain clinics at Avera McKinnon and around Sioux Falls. We have found that each clinic needs to work differently and figure out the best way for this to work for them. In one clinic, it is that piece of paper. It's actually laminated so it can be erased. It's handed to the patient upon check-in. At other places, it is in the office with the nurse being asked face-to-face. But the clinic champion and the providers at those clinics help us to understand what will work for their patients. We asked the 2 questions, and like I said earlier, if either of them are answered, sometimes for always, they are flagged as food insecure. And at these clinics, we are able to give them a bag of emergency food supplies. So this is in partnership with Feeding South Dakota, and is done in part with our Healthy Start program as well. So we have a dietitian in our Healthy Start program that orders the food that gets delivered to McKinnon and then gets boxed up by volunteers and then distributed to our different spoke sites across Sioux Falls. You can see an example of the bag here. You can see an example of the different foods that go into it and what our sort of pantry food bank space looks like at McKinnon. But each week we're getting these deliveries, we're getting these bags to clinics. Clinics are doing the screening, and if food insecurity is identified, able to hand a bag to that individual. This is again a really great example of like, we want to do everything that we can for people. So when we started this, it was like, yes, we're going to have these bags, we're going to have fresh produce, and we're going to have frozen ground beef, and we're going to have milk, and we're going to get it to 19 clinics across everywhere all the time. We tried that for a minute. It was a little challenging in our hub and spoke model. So we have found that what works best for us is focusing on these non-perishable foods. Clinics are able to keep these at their locations. We can keep them on shelves. You can still include things like milk. There's shelf-stable milk. We have all the food groups represented here. We do our best to pair foods and include educational materials about how to prepare the foods. So we're doing what we can, but at the end of the day, we're getting food into the hands of our patients, and that's what we are trying to do first and foremost. We have this operating at McKinnon and those few clinics in Sioux Falls. We're also doing this in Pierre and Parkston, also Lake Andes, and plans to expand to other places in our more rural areas of our footprint. I wanted to show just a bit of information from this food pantry work to date. So this is 2025 through, I pulled these numbers a few days ago. So this would be through March. This is the Sioux Falls locations. And when we first started in Sioux Falls, we were just focused on women's and children's on the McKinnon campus. And then you can see this bump in bags handed out is when we expanded to other clinics in the Sioux Falls area. In Sioux Falls, we are focused on women's and children's. That is our highest priority. That is what our Healthy Start grant helps to support as well. In Pierre and Parkston, the food screening and bags are available to everybody. This is the Pierre and Parkston numbers. So Parkston was actually the first to launch and sort of paved the way for Avera doing this work in other places. I put a box around when Pierre joined the fray in late October. So you can see the numbers have jumped up there as well. And so this is just in total what we have given out across all of our sites starting in 2025. So we have nearly 2,800 bags. You can see the number of children and families that we have reached. In our partnership with Feeding South Dakota, we do have to report a little bit of information back to them about the number of patients we have served, but they in turn give us information about the number of meals and the number of pounds of food that we are able to distribute. This has been a really valuable partnership because we can meet needs where they're at. Like Dr. McKay said, we don't want to screen and identify an issue that we cannot address. So here we are able to address it. It's also really helpful in our rural areas that might have a food pantry in their town, but maybe it's in a church closet and it's open for 1 hour, 1 day a week, every month, and it's your neighbor who runs it and you don't want them to know that you're food insecure or you need help in this space. And so hospitals are really good at maintaining privacy. We help to do this through the bags that we give out. You know, you can't see what's in them. They're Avera branded. They look like what you take your patient supplies home in. But we've worked hard to provide as much dignity and discretion to that process as we can. So a couple of things that I will leave you with today: screen and intervene. If you take nothing away from this, screen and intervene. There are lots of different models for how to intervene. It's not going to be easy. It's not going to work overnight, but it can be done. And like I said before, there are 3 different models that are happening right now. Avera is different than Sanford, that is different than Monument, but they are all meeting the needs of their patients in different ways. So it can be done. You just need champions and persistence and a little bit of crazy. But it is really important work, and the stories that we hear from patients definitely make it all worthwhile, especially when you're operating in that maternal and child space. Universally screening, connecting all patients to resources no matter what. And then the thing that I didn't talk a lot about, but is one of the reasons why I'm so jacked up right now, is advocacy and education. So I actually came to this presentation from Senator Round's office talking about food as medicine programs and expanding funding in an ag supplement bill and the type of work we're doing in that space in South Dakota. And so even if you can't screen and intervene in your clinic right now, you can advocate and educate on behalf of your profession and on the behalf of your patients. I do a lot of this work through my professional organization. The American Academy of Nutrition and Dietetics makes it really easy to just click and send an email or read this script as you call your senator's office. So signing up for those things, engaging in that work, and just making your voice heard. You might not say it perfectly or right every time, but showing up is what matters, and we are doing this for the children. So thank you so much. We are happy to take any questions you have.
You know, OBs think that pediatricians are just a quiet bunch.
I guess, what do you recommend for families who are not eligible for SNAP and WIC, but still encounter food insecurity, particularly if there's a family that has an allergy and needs like a specific formula or a specific diet?
This is really tough. There are local resources that do not ask questions about your income or other things and just make the resources available. That doesn't address the issue of special dietary needs. However, if you can have some of your food needs alleviated in that way, it could free up money to spend resources in other ways.
On that family, when I get that, as a pediatrician, I'll hand them, or they get the sheet, I see that they screen positive. My nurse will have already asked if they're interested in that bag of groceries. When I walk in the room, I know a little bit about that family, know their background, but followed them for a while. Know which way to approach food insecurity a little bit with them, what I think maybe. I've learned that my judgment is not correct a lot of times too. But in that situation, I may introduce, do they know about fair market? So the grocery store that's across from Bagel Boy, and say, hey, there's a grocery store there that you can go. And they ask, can I just walk in? Do I need anything special? I said, no, it's just like any other grocery store. You can go in and they have reduced priced groceries there. So I'll direct them to that. The distributions, that's a little bit harder. There's lists for that. You know, there's Caris Ministry that has multiple food distributions. There's food, there's Faith Temple, there's Brandon has, but I don't get into those as much. The QR codes can help direct that because their timing is of such, but I'll visit. But if they do have SNAP or WIC eligibility, I try to get them involved because that gives me the most longitudinal care for that family, and have a coordinated care person that I can invite for those families that need additional resources that they talked about, housing and other positives. That at least I have that in my clinic. I can bring that person in and say, hey, can you touch base with them?
This is a place where community health workers can be. We might.
Thank you everyone for your time and attention. It's great to see you all here today, not just for the free lunch, I'm sure. We will be back soon.
Yeah.